Hello, everyone. I know everyone's getting their food, so feel free to grab food, take your seats, and thank you for coming. I know it's the last day of the conference and everyone's a little tired and worn out. We have a really good session for you. We're doing a presentation on high-intensity interval training. We also welcome any virtual attendees that might be coming in. So we will be doing a Q&A panel at the end. We recommend if you want to submit questions throughout as you think of them, that's fine through the app. We have the app. You just have to go through your, go on through the session from the NACFC app and you can go to submit questions. And then we will have questions after all the presentations. Okay. I don't think I introduced myself. I'm Chelsea Rogan. Sorry. That's supposed to be the first thing I say. I'm a physical therapist at University Hospitals Cleveland Medical Center, and this is a topic I'm really excited about. My special interest is more on the advanced lung disease side, but we are doing a whole presentation on high-intensity interval training, what it is, how to program, what we can do with our patients kind of throughout different levels of ability. So it's not just for our super healthy patients, but it's for all of them. I'm very excited. I'm going to have Taylor Lewis come up, my co-chair right here, and he's going to go through some of the session objectives with you.
All right, so it's good to see everyone on the last day. So learning objectives for today is identify the key physiological principles of HIIT training and assess readiness for interval training across the lifespan of people with CF. We're going to look at develop and advance HIIT programs across continuums for foundational to elite performance. And then we're going to finish with applying advanced considerations for individuals with severe lung disease, including safe use of supplemental oxygen during high-intensity exercise. So with that being said, we are going to get to our first speaker here and just get rocking and rolling. Now, our first speaker is David Felton. He's a physical therapist practicing at WVU Medicine, JW Ruby Memorial Hospital, and at the Mountain State Cystic Fibrosis Center's adult and pediatrics clinics. He's a board-certified specialist in cardiovascular and pulmonary physical therapy. His roles include physical therapy education coordinator, or he is a physical therapist education coordinator, site coordinator for clinical education, adjunct facility of the Western Virginia University Division of Physical Therapy. He received his doctoral physical therapy degree from WYU School of Medicine in 2010. So here we go.
Beautiful. Thank you. Man, it is an honor and a privilege to be here talking with you, amazing people, about something that's super fun. High-intensity interval training. It has intensity in the name. Can't get much better than that. So is everybody here relatively familiar with, can you raise your hand if you've heard of high-intensity interval training? Good start. Have any of you actually done high-intensity interval training? Really good start. All right. So I have nothing to disclose. I'm going to be introducing high-intensity interval training to a bunch of people who already know all about it and have done it. And then Drew and Chelsea are going to really get into the meat of how do we do this with our patients. So it's going to be good. So we already know how beneficial physical activity is. Exercise, physical activity, not exactly the same thing. Not all physical activity hits a therapeutic threshold. So when we're talking about moderate to vigorous physical activity, lots of benefits come into play when we hit that therapeutic range. Swisher in 2015 in their group recommended at least 30 to 60 minutes daily, talking about intensity level of 70% max heart rate. So the question is, how many of our patients are hitting 70% of max heart rate, 30 to 60 minutes per day? In reality, we're probably different studies, different results, but maybe 8 to 33% of children and adolescents, 25 to 40% of adults, people are physically active, but are we getting our activity levels intense enough to meet those therapeutic levels? So as far as we know, not as high as we would like to be. So some cited barriers to physical activity in CF from Denford: tiredness, time, illness, motivation, lack of enjoyment. And this was 2020, so pre-modulator right before. So now that we have ETI, some of these, maybe many of these, could possibly be improved. Maybe not as tired, not as sick, maybe more motivated, and maybe exercise is more fun now, possibly. So a nice ripe opportunity maybe. So 2022, Gruet and al. Published this article on a rethink on physical exercise training in a modern era of cystic fibrosis. So they had several key points that I just wanted to share. One is we've got to individualize what we're doing with our patients. This is very difficult to do. We're not there. I think we want to get there. It's hard, in our sessions talking about exercise, there's a tendency like, we have to generalize because it's very difficult to go specific for every patient. And the gold standard would be to individualize their exercise regimens for each patient. And this is because each person has their own psychological response to a particular activity or exercise. They have their own interests, and they have their own factors that affect how they can integrate exercise into their daily lives. We have to have sufficient muscle loading. We referenced this earlier on that first slide. In order to get therapeutic benefits, we need to have enough intensity. A combination of aerobic and resistance training is key for all the benefits that come with aerobic exercise, with airway clearance, with fitness, with quality of life, but also resistance training with muscle mass, bone mineral density. And one of the things they really stressed was the importance of early integrative neuromuscular training, essentially getting started early in life. Developing physical literacy at a young age and developing positive thoughts and behaviors and attitudes that's going to carry with the person throughout the lifespan. They really felt strongly about sports at a young age. Not everybody likes sports, but it really does it's a package deal that really accomplishes a lot of what we need for our patients. So, wouldn't it be nice if we had something that accomplished all these things? Enter high-intensity interval training. So what is high-intensity interval training? It's a form of exercise that alternates short bursts of intense effort with periods of rest or lower intensity effort. So here in this diagram, you can see we've got lower intensity exercise for maybe 2 minutes, and then maybe just like a 20-second burst of high intensity, really hard work. But then we're back down to an easy pace, and then alternating intervals. This is the general framework of what high-intensity interval training is. So, advantages to high-intensity interval training. It's highly customizable. So, we can customize based on a patient's fitness level by simply adjusting the work-rest ratio. Longer rest, shorter work, and we can progress as the patient becomes more fit. We can customize based on environment. This can be done at home, it can be done in the clinic, it can be done in the hospital setting, it can be done in the community or at the gym. And then you can also customize the exercise modality based on the patient's interests. You can use body weight if you don't have any equipment. You can use equipment if you have equipment. And then you can vary and integrate, and you don't have to do the same thing within a certain workout. You can make it more interesting for the patient. HIIT is very time efficient. I think this Salkas article referenced that you can get same or better benefits from HIIT as moderate intensity continuous training with 40% less time, which is significant for our patients. Surprisingly, reduced ventilatory limitation with high intensity interval training compared to continuous training in the CF population. This seems to be because while you're working very vigorously, those rest periods allow for breathing recovery, which is much better tolerated even in advanced disease. We're training aerobic and anaerobic, and then maybe most importantly, just the potential for gamification, fun, and better adherence, which tends to be a little bit more enjoyable than just steady state exercise. Patient preference, but still. Evidence for HIIT. It's really good at improving VO2 peak, which we measure with CPET. And so if you have something that is going to strongly predict prognosis and mortality, we want to try to enhance that as much as possible. VO2 kinetics is also improved by HIIT. This is how quickly your body is able to adapt to physical activity and increase O2 supply. So, for instance, if you have CF and you start to do something and you feel tired quickly in response to that exercise, you may have less affect towards that activity because it made you tired. But if your body is able to adapt quickly to that exercise and you don't feel as tired, you may have more favorable views towards moving and continue on. Body composition, increasing muscle mass, decreasing fat mass, and improving bone mineral density. So we've got a lot to say for this little exercise strategy. All right, so some examples of high-intensity interval training. So these aren't play. Not exactly technically formal training, but these carry some of the same principles of interval training. So if you ever played freeze tag, sharks and minnows, red light, green light, you're having bursts of activity interspersed with rest or lower activity. So these are great ways for especially your younger population to play, but still getting principles of interval training. Man, I don't know who Simon is, but this guy carries a lot of power in the youth sector. Because you can ask a child to do something and they won't do it. But if you say Simon Says, they will just go to town with you. So I love Simon Says for HIIT training with kids because you can say, Simon Says, do 10 jumping jacks. And all of a sudden they'll do it. It's amazing. And then Simon Says, stand on one foot. And you can just direct an interval training with a game and they have no idea that they're working out. Many sports mimic principles of high-intensity interval training where you have bursts of activity interspersed with rest. In soccer, you may have a sprinting near the ball, but then you're jogging or waiting for the ball to come back towards you. Basketball, same thing. And then actual formal training. So you have the option of running and then walking, or stationary biking at a high intensity and then at a low intensity. And then you've got some formal types of HIIT training that have been made popular through CrossFit, for example. Tabata training is where you do 20 seconds of work interspersed with 10 seconds of rest. Every minute on the minute exercise is where you do an exercise or 2 or 3 or whatever you set every minute. And so the quicker you get it done, the longer your rest is before the next minute starts. As many reps as possible is where you have a set circuit training exercise with several exercises, a number of reps, and you're just going to cycle through and you give yourself a time limit and see how many reps you can do in that amount of time. And so this is really fun because you can give yourself a score at the end of your workout that you can try to compete with somebody else or you can compete with yourself. I said segmented because normally these would be 15 or 20 minutes long, but you can break it up and do 3 minutes, 1 or 2 minute rest, 3 minutes, 1 or 2 minute rest to give yourself more of a break based on conditioning. And then also for time as another type of fun exercise where you are, you have a set exercise, and you're going to try to see how quickly you can get it done. So if you get it done in 9 minutes, great. 20 minutes, great. It's the same exercise, but you can compete with yourself to see how quickly you can get it done. Okay, so what should we know before beginning high-intensity interval training? General criteria for readiness would include basic clinical stability, so no active hemoptysis, no IV antibiotics, hospital admissions within the last 2 to 4 weeks. We want to have good baseline resting SpO2, no recent musculoskeletal injuries that we're going to exacerbate or re-injure. And then we also need to consider medication effects that the patient might be on. So for example, fluoroquinolone antibiotics are a class of antibiotics that can interfere with collagen synthesis. So this can cause tendon changes, surprisingly in some studies, even during a single course. So we do need to be aware and be cautious. There's a potential for tendon ruptures, particularly Achilles, and this increases with age and prolonged use. So if your patient is on fluoroquinolones, then you would want to avoid high impact, high intensity explosive exercise types for at least 2 to 4 weeks after. This doesn't mean you can't do exercise, but you need to reduce the stress on the tendons with the type that you choose. And then corticosteroids similarly can impact bone formation and also tensile strength of tendons, but really with prolonged use and with systemic use, not necessarily with inhaled. So another thing to be aware of, especially if your patient is on both, because concurrent use increases risk in particularly. Additional injury prevention thoughts. It's helpful to do a basic musculoskeletal screen. We talked about make sure there's not pre-existing injury that they're going to bother. If they have existing tendon or joint pain, maybe we don't want to exacerbate that with explosive movements. And then being mindful of bone density scores, osteoporosis, osteopenia, and flexibility. There's a tension that we were just talking about with Thaler, HIIT increases bone density, which is good, but also if you have too low bone density with explosive movements, is there a risk for injury, and what is the fine balance? So we need more studies to figure out, specifically what we need to do, what is needed, and what's beneficial in these populations. And then following appropriate training principles, warm up, cool down, using appropriate exercise technique and quality to prevent injury, your workload and your progression rate, and then modifying based on medication risk and risk factors. And then monitoring response, if the patient, we want to instruct our patients on this and be aware of ourselves if we have persistent post-exercise symptoms, unusual sputum production, severe dyspnea, chest pain, presyncope, drops in SpO2, and then especially, if you have CF-related diabetes, being aware of the risk for hypoglycemia during or post-exercise, and appropriately planning with carb and medications. All right, and then finally, just going into some specific lifespan considerations for HIIT throughout the lifespan. So for the pediatric population, again, our goal is primarily we want kids to have positive attitudes and beliefs towards exercise. So we want them to have good neuromotor development, physical literacy, and we want to make sure that they enjoy physical activity. So we do want to be aware of weight, BMI, nutrition whenever we're exercising. It's an important phase in this growing phase of life. And then we also want to make sure the patient can report symptoms to be aware of for us. Needing supervision. When the kids in this age may need help with monitoring for hydration, and then if there's asthma, bronchoconstriction, monitoring for that as well from a safety standpoint. And then I'm primarily thinking about trampolines, not necessarily a part of HIIT training, but with really young kids, trampolines are not the best anyway as bones forming, but if there's any low bone mineral density, getting on a trampoline with other kids or adults is really kind of a recipe for disaster. So practically speaking, with kids, we want to use sports, games, relays, make it fun, not so much about performance, not about results, but just having fun and enjoying movement. If you are doing something more structured, they're going to do better with short bursts of activity and play-based intervals. So for adolescents, we are continuing to build on positive physical activity behaviors and interests, but being aware that social motivations comes into play here, which we can use for our benefit with engaging our patients. And we can start to try to teach training principles and knowledge about how to exercise. So we want to make sure we've got stable nutritional status and we're learning about pacing and effort. If CFRD is emerging, we want to teach about how to monitor with that from a safety standpoint. And then, at this phase of life, body image can start to play a big role in why people want to exercise. And so we can just kind of be mindful of that as we're teaching and going through this. Practically, peer involvement is going to help with improving compliance. Sport participation is always helpful. We're finding ways to make it competitive. We mentioned ways that you can do HIIT exercises in a friendly, competitive way by scoring, and that can be really helpful and fun. And then just worth mentioning, it's a tech savvy generation. So apps, gamified trackers. One of my patients was talking to me about how they were using TikTok to look up core exercise training that they were interested in. So your patients may already be doing some of that if they have some interest, and you can engage and point them towards especially good resources. For adults, we're starting to get into a phase where we're wanting to increase or preserve muscle mass and strength and aerobic capacity while also managing potentially building comorbidities. Stresses of life, work responsibilities can decrease time. So this is where we can really potentially advocate for HIIT as a potentially good option for people with its customization options. We may need to start being aware of the potential for hypoxemia with exercise here. Again, glucose monitoring and considering low impact modes based on bone density. And finally, for older adults, the priority here is preserving bone, muscle mass, physical function, and quality of life. From a readiness standpoint, we may be looking at, does this patient, when we're doing high intensity exercises, does this patient have any cardiovascular disease risk factors that we might want to be aware of? Our vital signs may start to come into play here. Heart rate, blood pressure, SpO2, are they acceptable at a starting point for exercise? We may need to avoid ballistic or impact exercises based on bone and other training conditions. And then just being aware of high fall risk if we're doing more athletic movements. Is the person ready and safe to be able to do those? Probably need to plan on longer recovery intervals, but again, this is adjustable based on the individual and fitness. And it can be very beneficial to encourage social and group-based formats as well for this group. So in summary, HIIT is meaningful from a health and wellness standpoint, safe and effective, efficient and enjoyable, and most importantly, it's adaptable and customizable for the individual. So I'm guessing that you are great, you're sold, now you want to know, okay, how do I do this? And you are in luck because now we have Drew ready to come up here and tell you how to get this done. So thank you. Here are my references.
Okay. That was a great segue for our next speaker. This is Drew Strube. He is a certified strength and conditioning specialist and a strength coach at Waukee High School in the Waukee High School District in Central Iowa. He has led all sports at the high school throughout their multi-year progressive strength and conditioning program since 2021. Prior to joining, Drew served the Greater Des Moines community as a trainer and coach in the private sector beginning in 2007. During that time, he worked with individuals ranging from 14 to 72 years of age following his academic and athletic career at Iowa State University. During his undergraduate studies at Iowa State, he volunteered with Olympic sports as a strength coach, primarily implementing structured strength and conditioning programs to women's soccer, track, volleyball, and women's swimming and diving. Following the completion of his football career at Iowa State, he volunteered as a strength coach for the Iowa State football program. He currently resides in Waukee, Iowa with his wife and 11-year-old son who is thriving with CF. Please welcome Drew. There you go. Arrows front and back right there.
Perfect. Perfect. Well, I will echo the same thing Dave said, and absolutely honored to be here. Thank you all for having me. And I think you're going to see a lot of crossover between what I'm going to tell you and what Dave has already told you. My goal is to help you understand how you take those things that Dave gave you and then actually put them into plan. How do we actually plan to implement into a program? And really it comes down to 3 phases: preparation, integration, and then the application of said plan. I do not have any relationships to disclose, so let's get right into preparation. Really, there's 2 big pieces to the preparation aspect, and that is the physical and the mental sides of it. From a physical preparation perspective, there's a lot of structural considerations. Dave laid out a lot of those, tendons and ligaments, muscular forces, technical proficiency is another big one. I think something that we need to consider when we're looking to program is there's a lot that goes into it, and it can be a very stressful thing on the body, both physically and mentally. So when we look at the structural, most people associate high intensity with high impact. I know Dave talked a little bit about some of those contraindications to that, but we need to make sure that we have prepared the tendons and ligaments through things like small hops into more skips, into bounds, and then jumping before we get into really higher intensity impact things, especially as we're talking about the higher proficiency level. The muscular forces that need to be produced in order to do HIIT training in higher level individuals, but then also the technical proficiency. HIIT can be used, as they've talked about, in all sorts of aspects, whether it be cardiovascular wise, even with resistance training. There is a technical proficiency that needs to be there because as the body and technical proficiency starts to break down, that's then where we are going to start to see injuries. Some systemic considerations would be a base level of general physical preparedness. Dave, again, hit on that. I feel like he stole half of my conversation that I wanted to have with you today, so all good there. But the other big thing there is the CNS's ability to recover. The central nervous system is a very complex thing that we know a great deal about and also very little about at the same time, but we know that it receives all stresses as stress, whether that be home, work, life. The ability to recover from high-intensity training has been shown to be somewhere around 72 to 96 hours to truly maximize those things. Does that mean you can't do some form of HIIT training every single day? I don't know. I think that's dependent upon you, your client, and your comfort level with it. The mental preparation for HIIT, the ability to handle discomfort. High-intensity interval training can be extremely uncomfortable. If you have someone who is not at a place mentally to be able to maybe push through some of that discomfort, is high-intensity interval training the best option for them? Modulators, the positive and negative effects of them. When we're thinking about utilizing this with a client or a patient, what is a modulator, someone on a modulator or off a modulator? I know that in my own son, I've seen a huge difference in him on a modulator versus off. He's very confident in being able to go do anything, and maybe that's just because he's 11 and he wants to take over the world. I don't know. But the confidence that someone going from having a 40% lung function to an 85 or even 90% lung function, they may be overconfident in what they're able to take on. So being able to understand that mental consideration, you might also have someone who's on a modulator who is dealing with, I saw my friend on a modulator go from a 45 to an 80% VO2 max, and but I've only seen a 2 to 3, percentage point bump. What does that do for their ability and their confidence in themselves to be able to perform something like a high intensity session? Depression and anxiety, we know that along with things like Trikafta and some of these other modulators, there have been signs of depression and anxiety that have come along with them. What does that do for their motivation levels, their ability to handle this type of training? So all things to consider. And again, the central nervous system, it only senses and reacts to stress. So the stress of managing my care, managing my family, managing whatever, all of those things are going to have an impact on their ability to perform high intensity training and or perform it well. So when we get into the integration, there's 3 big questions that you always have to ask when you're looking to program something like HIIT and really anything. Why, when, and where? Why integrate? What stimulus are we trying to get out of using high intensity interval training? What adaptation are we trying to get out of this? Is it simply we're trying to increase VO2 max? Is it trying to reduce the number of treatments they have to do every week? That's a big one right now. I think you have to ask yourself, is there another modality that could accomplish this that's not HIIT training? There is always another modality. Is that modality limited in its application? We have to weigh these things. Is HIIT the best option, or why is HIIT the best option? And then the risk or reward for using it. A lot of contraindications that were mentioned earlier as far as, hey, we need to be very, very careful around these things, both for using HIIT and for not using HIIT. Again, going back to that psychological aspect, people talk. People with CF have friends. They see other people doing high-intensity interval training. Maybe they want to do it, but maybe they're not ready. So what are the reasons for doing it and for not using it? Why integrate? These are all questions we have to ask as we're looking to program this for anyone. When to integrate then? What are my beliefs and standards in order to qualify for HIIT integration? Because I truly believe that anybody can do HIIT training. I truly believe that. We talked, it could be anything from games to you could be talking high elite level athletes. Anybody can do it. Our differences are in scope, not kind. We can all do it. But what are your beliefs as someone who is integrating this as to the standards that need to be met in order to qualify for someone doing HIIT training? A well-known strength coach by the name of Jim Wendler once said, if you stand for nothing, you will fall for anything. What are your beliefs? They're not right, they're not wrong, but you need to know why. Do you have a base level of GPP, general physical preparedness, that you feel like someone needs to have before you are comfortable putting them through that? Is HIIT necessary to achieve that adaptation? Going back to the why do we want to do this? When do we integrate? Have we progressed to a point of physical and mental preparation with it? Have we taken into consideration all of these things? Have we prepared this individual for some higher intensity things by starting them off with more fundamental building a foundation of general physical preparedness before we move into HIIT training? But also the subjectivity of high intensity. I'm 42 years old. I work out regularly. My resting heart rate is of a healthy level. That is a very different high intensity for me than for an individual who is 50 pounds overweight or has a degraded lung function or has never exercised. Very, very different things. But that is a subjectivity of what they consider high intensity. Yes, we have some definition of 70% or higher of max heart rate. But could we utilize some of these things and some of these modalities at a lower intensity heart rate? Are there structural or systemic considerations that we need to take into mind? Are they on different medications that could be whatever the word is, make you not want to do it, right? Trying to sound smart. That's not me. And then where to integrate. Where we want to integrate within the macrocycle, the mesocycle, and the microcycle of your plan. So when we're thinking about planning and programming for an individual, your macrocycle is more of your annual plan. What does this look like across this year? Maybe your macrocycle is 2 years, 4 years, dependent on you and how you define it. But it is dependent upon the individual and is dependent upon the annual plan's primary objectives. What are we trying to get out of this year for this patient? And then in that phase that you're in, that you're considering utilizing HIIT, what are the objectives of that phase? Are we really focused on increasing bone density? Are we focused on increasing just general physical preparedness, or are you focused on increasing lean body mass? All of them. But what are those current phases? And that will then lead you to that microcycle or that daily workout. Should HIIT be a whole session thing? Should it be enough that it's a whole session? CrossFit, it's all HIIT. The whole thing. You see other programs will utilize HIIT as what they call a finisher, a way to just kind of really wipe you out at the end, or utilize a semi-fatigued state to then push your conditioning to another level. Or should it be, if HIIT is really something that we're really focused on, should this be the first thing in the workout, and then we can hit some accessory stuff that's a little bit less important on the back end? So these are all things where we consider where in our annual plan and where in our day we integrate HIIT training. And then the final application, what are we going to apply and how are we going to apply it? So what? Have to ask this question, what do I want to accomplish? Goes back to that what is the adaptation? GPP, lactic threshold, muscular endurance, muscular hypertrophy. What do we want to get out of this? And then is the patient client, what are they most prepared for? We could talk about all sorts of, we mentioned Tabata, we mentioned games. That is a huge spectrum of what high intensity interval training could be. What are they most prepared for? And I'll touch on how I kind of get to this here in a moment. And then the how, the modality, the intensity, and then how do we progressively overload this? The modality. If you're just beginning someone or you've got an older individual, you're probably not going to have them do sprints. Maybe we use something like a ski erg. Maybe it's in a pool. Maybe it's swimming. Intensity. 70% to 100% is a large frame of your max heart rate. What are they prepared for? What intensity do we want to work at, or do we feel we need to work at in order to maximize this? And then how do we actually progressively overload this? How do we progress this? Yuri Verkhoshansky, Soviet scientist back in the 60s and 70s. It's a very clear statement of an organism will only adapt to the stresses you place upon it. If you do not continually push your individuals to go a little harder or go a little further or push them outside of their comfort zone, they will never make the adaptation you're looking for. So in practice, just real quick, how I approach this, my philosophy on HIIT specifically, and then some example protocols on how I would use things from a beginner through more advanced. My training philosophy is the body is extremely resilient and adaptable, meaning people are capable of way more than they think. I think our jobs when we're trying to help people maximize their health and fitness is to help them believe in themselves. So many times working with teenagers to older individuals who will say, oh, yeah, I can't do that. Well, how do you know? You haven't tried. How can we believe them and show them that they are capable and more resilient than they believe? Start low and progress slow. A little contradicting to what I said there with you can maybe push people harder than they think. But wherever you think someone is, my recommendation is I always take them back one step and start there. And the reason I say that is because that allows for longer progression, more success, a better psychological impact on I am progressing for a longer period of time. I'm probably going to see more enjoyment out of this, which means I'm probably going to stick with this for longer. Technique, consistency, and intensity, always start with technique. Technique breakdown, form breakdown is where someone's going to get injured. Once they can do that consistently, then and only then do we start to add intensity to it. More intensity as far as ground contacts, external resistance, etc. Don't be afraid to cut your losses. We're at a science conference. I want to make something real clear. There is no right or wrong answer to programming. It is every bit as much the scientific method as anything else you are going to see here. You have a hypothesis based on information that you have. You implement it, you guess, you monitor, you follow. Don't be afraid to say, nope, I was wrong. The more we're wrong, the more we learn. And then why? For me, if I can't tell someone why we have something implemented into their programming, we should not be doing it. How will this help me get my goals? If I can't answer that question, we should not be doing it. I would urge you to ask yourself that same thing for everything you implement, including HIIT training. With HIIT, I believe anyone can do it because it does just vary in intensity. Walking, not walking. Jogging, walking. Jogging, not walking at all. Very low intensity, right? And elliptical, almost no intensity. Swimming, almost no intensity. Sprinting, plyometrics, Olympic weightlifting, deadlifts, high intensity. Anyone can do it. You can perform it regularly so long as recovery and capacity are adequate. We pointed out high-level sports. I think a great example, I coach football, so I'm just going to use this. I also coach high school football. It is 7 to 8 seconds on, 35 seconds off. A 1 to 4 work to rest ratio. A great indicator. Super high intensity, running into other human beings at full speed. I'm going to stand here and look at a bunch of these sweaty dudes in a huddle. Sports are such a great example of it, of how you can do that every single day. They practice that every day, so long as their recovery and their capacity are adequate. It is not necessary for most people to get their general health and fitness desires. Not saying that you shouldn't use it, but there are a million ways to skin a cat. And then for me, programming, I think it's great. We did not actually talk about this and touch base on the 70% to 90% plus, but that is actually where I personally say if you're not programming at above 70% max heart rate zone 3-ish, then you're probably not getting the benefits of the HIIT training of what you're looking to do. All right, protocols. This is what you guys want to understand. These are my favorite protocols that I use with athletes and that can be used with anything from low-level athlete beginner all the way to an elite athlete again. It just varies in what we're trying to accomplish, our intensity, not the kind. So a 2-4-6-4-2 match. I have historically done this. This actually came from more of a strength training base that I tried to apply to conditioning that found great results with, based on what's known as a pyramid structure in weight training, where you will maybe pick a weight, do a low number of reps, and then continually increase the reps and then back down with rest in between. So with this situation, you would go 2 minutes, hopefully getting yourself above that 70% heart rate, and then take a minute back down at a very low heart rate. It could be complete stop or just super low intensity. Go to 4 minutes. Try and match that same heart rate. Try and match that same speed. Back down. 6, down, 4 down, 2 down. you will find when you get into that 4 and 6 and that backside, that heart rate will get back up. You're probably looking to live in that zones 3 to 4, 70 to 80, 85% of your max heart rate. 1-to-1 work to rest ratio. This could be done both resistance training wise. This could be done in just about any modality you can think of. You could play a game with it. Simon says, and we're going to do this thing for a minute, and then Simon doesn't say anything for a minute. Or maybe it's 30 seconds. Maybe it's 10 seconds. But a 1-to-1. This could go anywhere from zone 3 to zone 5 for your heart rate. This could get it up depending on how intense that minute on or that 1 on is. I use the minute just because it's 1, but it could be 10 and 10. It could be a minute and a minute, 30 and 30, 45, 45, 3 minutes, 3 minutes. Really not super relevant, but it could be reps, which we'll get down to in the resistance training piece. A 1-to-2 work to rest ratio, similar protocol. Your 2-to-1, obviously a much higher work ratio to rest. That is probably, you're going to use more of that. You'll see more of that with more high advanced athletes or advanced individuals, because the work is so high. The rest can potentially be extremely low, giving very, very minimal recovery for it. Now, I have toyed with resistance training aspects outside of just Tabata, which I thought it's awesome that you mentioned that, because not a lot of people utilize Tabata training, which is a 20-second on, 10-second off. Again, let's talk about beginner. I'm going to do a wall sit for 20 seconds and then stand up for 10 seconds and do that on and off 8 times, 4 minutes. Maybe it's an air squat. Maybe it's a push-up. Maybe it's the way it was originally intended with an Olympic clean and jerk. That's elite. Okay. That can be one of the most effective, and if you haven't done it, I encourage you to go try it. Bring water and a towel. High-low movements. This is something I really enjoyed, which again, I've started experimenting with myself, that I really enjoy, and I've started to use with some of our high school athletes in order to condense a large amount of work in a short period of time. I like to use this along with the high-low stretch with some of our higher athletes at the high school level to try and mitigate the amount of time they're in the weight room, but more specifically through hypertrophy phases, where we're trying to create fatigue metabolites while still keeping intensity at a high enough level to maintain and build strength. What I like to do with the high-low movement is usually it's a compound movement, but something that can be bailed on pretty quickly. What that would be is like a dumbbell bench press, maybe it's a lunge, maybe it's a dumbbell overhead press, something that's a compound movement, but again, I can ditch the weight if I fail pretty easily. Take a weight that you could maybe do 8 to 10 reps with and do a set of 5, and then let's use this 1 to 2, or it's even use a 1 to 4. I'm now going to take a fraction of that weight and continue to do the movement for 4 times, for 10, 15, 20 reps. Very, very low impact, not a lot of stress to them, but building metabolites, flushing blood through the system. I'm now going to go back immediately to that heavier weight. Hit my 5. That just got a lot harder for that second set. Right back down, right back into active movement. Lower intensity, but still a lot of blood. You do that in 4 or 5 minutes, you can get yourself a whole lot of volume in a very short period of time, especially for those clients that might be time restricted. Similar type thing with a high-low stretch. This is something that I would really only use with really high-level people that can have a good mental space, because this is painful. We know that from a hypertrophy perspective, muscles in the stretch and lengthen position are going to create the largest tension. So again, using a movement that I could do, I think that the belt squat is a great thing for that if you have access to it, or like a goblet squat, push up, dumbbell bench is another one, where I'm going to pick a fairly heavy weight, somewhere in this 75 to 85% of my max range, and I'm going to complete it for, call it 10 seconds, 20 seconds, 30 seconds. I'm then going to just hold it in that stretch position for maybe a 1-to-1, a 1-to-2, a 1-to-3 rest ratio, creating tension and stretch through that muscle right back into. So even though I'm not actually doing anything, I'm holding an isometric contraction. Great for hypertrophy. Again, mental space for that. You've got to have someone who's willing to be in a decent amount of pain or discomfort, I should say. And their technique is spot on. Those are some of my favorite protocols that I really love to use and that I have found a lot of great success with. The biggest thing I would say with all of it is we're all scientists in some form. Take these things, try them, start a little light, build it up, experiment with them. Don't be afraid to just implement and figure it out as you go, because there's no right or wrong answer for that. I think that is the last bit for me.
All right. Last but not least, we have Chelsea Rogan, is physical therapist, clinical specialist at University Hospital Cleveland Medical Center. Chelsea received her Bachelor's of Science in Kinesiology from Syracuse University and her Doctorate of Physical Therapy in 2015 from New York Institute of Technology. Chelsea currently splits her time between inpatient CF, outpatient CF clinic, and the heart failure intensive care unit. She has worked with adult patients with CF since 2018 and serves as a physical therapy team leading and overseeing all inpatient care. Chelsea is also actively involved in the outpatient clinic as a member of the multidisciplinary CF clinic team, which has made it possible as part of an award from the CFF to support the role of PT in the clinic. Chelsea is currently working on collecting data on exercise testing during patient visits in outpatient clinic, along with post-intervention surveys to better serve the pediatric and adult patient population during their clinical appointments. All right, here we go.
Okay. Hi, everyone. Thank you. That was amazing. You guys did a great job. Thank you. I will be talking about advanced lung disease. Most of the stuff will be a little bit different, but kind of build on some of the topics that they helped us understand. I have no disclosures. So, learning objectives. I'm going to start with advanced lung disease. Most of us know what it is, but I feel like I can't do a presentation on exercise with advanced lung disease without at least defining it. We'll talk about some barriers to exercise, learn about some parameters to help guide session intensity, including safety considerations, and then also discover variations in supplemental oxygen to support those. And I have a video with some exercises towards the end of the presentation as well, with an individual with advanced lung disease. So we've all seen this, right? The definition of advanced lung disease, there's the FEV1 under 40 when stable, referral for lung transplant, and then one or more of the following characteristics. I am not personally very obsessed with the FEV1, but it is obviously part of the whole package. It's important. It's good to know where people are at, but I feel like sometimes our patients get very limited by it. So I want to help encourage our patients to kind of get past that number and be able to, work themselves and to be able to do things that they're able to do without focusing too much. Okay, these are some additional criteria associated with disease prognosis and worse progression and worse prognosis. I won't read through all of them, but frequent pulmonary exacerbations is part of it. Worsening malnutrition, supplemental oxygen with exercise and sleep. That's a little bit more relevant to my presentation because I am going over some supplemental oxygen considerations. And then we have CF-related diabetes, pneumothorax, and massive hemoptysis requiring ICU admission. This just really shows how, in addition to the standard CF care model, our patients and individuals with advanced lung disease do need a little bit of extra care, right? So we have regular 6-minute walk tests. We have consideration for transplant referrals, figuring out when to refer them if that's necessary, not waiting too late, but not doing it too early. Talking about palliative care, I've seen a lot of really good sessions during NACFC on supporting our patients with palliative care, advanced care planning, things like that, that might be a possible transition to transplant, or it might just be something that they deal with beforehand. Okay, so this is my favorite topic. And it's advanced lung disease with highly effective modulator therapy. We know that all of our patients can't be on modulators. Some of them don't qualify. Some of them had really bad side effects. But I am specifically talking about our patients with advanced lung disease that, so you see on the first part, I put a decline, steady or fast versus stability. So prior to modulator therapies, a lot of our patients, when they creeped into the advanced lung disease category, kind of first getting below the 40% range, not bouncing back up, we thought, okay, so it's going to be a decline, right? Hopefully it's a slow decline. Sometimes it's really fast. Sometimes one of our patients with advanced lung disease got a really nasty infection and then things went really quick. But that was kind of what was happening, right? So like we were just expecting, we'll do our best, but it's going to be a slow decline. A lot of our patients now with advanced lung disease are stable. And it feels different because they still have advanced lung disease. They still might be going through transplant referrals or evaluations, but we see them in clinic and they're just stable and low. So we want to maintain stability, but we still have to do all the testing every year. And some of them still go every year, every 6 months to a transplant evaluation where they say, hey, you're stable, like come back next time. So I really am interested in working with patients that are stable, but still might have needs, right? They might still need oxygen when they're exercising. They still have low lung function, right? So these are kind of the ones that were, I don't want to call them the forgotten ones, but like post-modulator, they saw some people like get into the 60s and 70s PFT-wise. And these are like the people that are like, I had a really good jump and I'm stable, but I'm not off oxygen. Or, I still need it during exercise. I still need it during sleep. I'm still short of breath, but I can do way more. Okay, so luckily, we already talked about some barriers to exercise, so I might not spend too much time on this. I think Dave might have even had some of the same studies that I looked at, so yay. But I highlighted in a couple of these. This one's a systematic review where it went through some different barriers. I highlighted the lack of time, which was mentioned in 3 of the 7 studies, and then also fluctuating health, exacerbation of symptoms, breathlessness, fatigue, coughing, which I would find a little bit more with our advanced lung disease population. Still other barriers. Time has been in everything, lack of time, right? So having CF makes you really cognizant of your time, what you have time to do every day. Our patients with this advanced lung disease might have even less time because they might still be doing a lot of the treatments that some of our other healthier patients aren't doing anymore. That is a topic for another time. I'm not getting into that today. But the lack of time really kind of gives this type of workout, the high intensity interval training, a really good school of thought because as we learned before, these can be quick workouts, right? So we're not telling our patients like, go walk on the treadmill for an hour. And they're like, an hour? I don't have that much time. These are quick bouts. I mean, it could be a 12-minute workout, a 15-minute workout. These, I think, this is a workout that I think that it should be utilized more with this population because they have a lack of time. Okay. So safety considerations, some of the same ones we talked about already. We talked about bone density. I think we got into that pretty well. I'm not going to continue on that, except we do know that with our advanced lung disease population, some of them do end up having osteopenia, osteoporosis. We know that generally some of their health might be a little bit lower than the healthier population, so that would also cause other metabolic changes. We just should be aware of these things. So these are not up here as, if they have low bone density or if they have a low BMI that they shouldn't be doing it. It's just things that we should take into consideration when we're creating a program. We want to keep in mind their cardiac status, blood pressure, so make sure that their blood pressure is in a good range. And then heart rate, I do want to touch on this a little bit because we did talk about earlier, and I will talk about kind of the heart rate training zones. Some of our patients with lung disease will be tachycardic at rest and during exercise. And it doesn't mean that they shouldn't exercise, but they might have a resting heart rate of 100, 105, and that might be normal for them, right? So we all know that if your body is not carrying oxygen the way it should, your heart might kind of come in and compensate. So it'll say, you know what, I'm going to pick up the heart rate. We want to carry oxygen around to all the muscles in the body, so we're going to compensate by increasing the heart rate. That's common. It happens. We can still use heart rate training zones, but I will also go over some other areas that I like to focus on if the heart rate training zone isn't quite as accurate as I want it to be. Oxygenation, we want to discuss with RT and our goals, and I have some of my team RTs here. But that's really important to get on board with your team, the RTs, the team, either the pulmonologist, just to see what the goals are. Sometimes the goals might be 88 to 92. And I know that might sound a little scary to some people, like 88, like that's really low. That might be the goal for some of our patients. They might hang out at 88 to 92. That might be normal for them. Obviously, I think we can all agree that we do not want oxygen to be below 88. So I would never continue exercising if it was below that. Some people might have goals for 92% and greater. So we just want to be cognizant of the team goals. This is like a little trick that I figured out. I don't know if anyone has tried to get a good pulse oximetry reading with somebody exercising outdoors, but apparently the sun affects that. And maybe some other scientists could tell me exactly why, but sunlight can negatively affect it. It disrupts the PPG signal. I cannot pronounce that word. So if you are exercising with somebody or you're advising somebody with advanced lung disease that does a lot of things outside, you would want to have them get into a shaded area or get it like underneath some clothing so they can read it a little bit better. Okay. Safety considerations continued, shorter bouts of exercise and longer rest breaks. So we learned a lot about the different, the ratios, right? So there's like the 1-to-1, the 1-to-2, the 1-to-3, maybe the 1-to-3 I made up myself, but anyways, we'll get there. Basically adjusting the ratio, right? Longer rest breaks and maybe shorter bouts of exercise, depending on what people can handle. If there is a desaturation event, it doesn't mean, oh my goodness, we have to stop exercising completely. We take a break, we wait till it's back in the range, and then we continue on. Obviously, if that comes along with extreme breathlessness or they can't continue, that's another thing. But just a desaturation event does not mean they cannot continue. If there's no recovery, then that would be maybe adjusting oxygen levels if we're able to, like supplemental oxygen amounts. But I wouldn't completely, I think some people get really alarmed, like, oh my gosh, I just saw 85%, like, go home, this is too much for you. That's not what we're doing. We're giving breaks, we're being safe. We are getting the right amount of oxygen delivery. So there are so many, I think there could be a whole presentation on oxygen delivery, but there's no time for that. So we want to make sure our patients have the right amount of oxygen and the right delivery. Even just talking about nasal cannula, low flow, high flow, there's non-invasive ventilator systems. There's been a couple that have been on the market. One of them is going off the market. I'm not promoting anything, but anyways, they can be very helpful for our patients. Okay, so this is what I was mentioning earlier when I said that we want to look at the heart rate zones, and this does correlate with what they were saying also, the 70% and above. However, these heart rate zones also correlate with the Borg scale, and I use this scale a lot for our patients. So this is a scale that rates intensity. It goes from 6 to 20 because it's supposed to correlate with your heart rate. So sometimes it's really important to find out where somebody's exercising by asking them for a number. So there's a chart, which I didn't put up here, but everything correlates. So like an 8 to 10 might be light on the scale, or 11's light on the scale, but this is a little off. Either way. Giving them the option to tell you how they're feeling versus just looking at the numbers is important. So for the light period, which might correlate with 50 to 60% of their heart rate, or an 8 to a 10, that might be part of their lower intensity part. So I know we talked about how like there's the higher intensity interval and then there's the either lower intensity or rest. That could be correlating with the light range. It might also correlate with the heart rate, but it might not. To calculate heart rate max, the 220 minus age is super easy, but it's not great for this population. I really prefer to use, there's a lot of different formulas. The Carvonin's a good one, so that looks at your heart rate rest to find the best heart rate versus just the 220 minus age. So it uses the patient's resting heart rate to correlate this. Which is good if they have a higher resting heart rate because that could better give you an idea if they're in the right zone. The higher intensity bouts would be anywhere from like the high to vigorous. So they would probably rate their workout anywhere from a 14 up to a 19 or a 20. Okay, and this is just to be clear, this is just to make sure you're getting them in the right zone. So we can use heart rate max, but there's also other ways if it's not working quite as well. So I did talk about this a little bit with the work to recovery ratio. You can adjust this as needed. I'm just giving an example for an easier one. It could be a 30-second on and a 90 seconds off. I use on and off because some of the exercises, the off period isn't just pure rest. It might just be a much lower intensity exercise. You could start them with 5 or 6 sets, which would be about 10 to 12 minutes. So if you're looking at 30 seconds on, 90 seconds off, each set is 2 minutes. And 10 to 12 minutes might be enough. They might say, wow, that really tired me out. That was a great workout. And that could be great for somebody that says, you know what, I only have 12 minutes in my day extra to work out. And you will hear that from people. They'll say, I don't have any extra time in the day. And I get that. You could advance them to shorter rest breaks. So either like a 1-to-2 ratio, 30 seconds on, 60 seconds off, and then you can add more sets. So instead of 10 to 12 minutes, it could be 15 minutes. It could be 20 minutes. Okay, so I have some videos of an individual with advanced lung disease. He has used exercise to really help himself stay stable. So he's 38. He has been on Trikafta since 2019 when it came out. And he was as low as 16% FEV1 when he started Trikafta. He has been stable in the mid-30s since he started Trikafta, but hasn't gone any higher and kind of knows like probably not going to get any higher. And I know we don't know, but I think a lot of people are like in the first couple of years after starting it, they're like, oh, I'm still going to get higher. I'm still going to get higher. And then they're like, okay, I'm just going to hang out around here. This stability is a good thing, but still needs oxygen for exercising, still needs oxygen for sleep, but is using high intensity interval training to help keep himself healthy. So I'm actually going to show some videos, and you might notice that the high intensity doesn't look that high, right? So we talked with Dave and with Drew, and we talked about some of the really high intensity exercises. These are high intensity for him and for other people with advanced lung disease. It might not look high intensity to us. Okay, so just little bits. So this is one of the faster bouts. I won't, we're not going to do the whole 30 seconds, but we did a 30-second on, 90 seconds off. And this would be, a lower intensity. So it's slow, right? But easy, right? So this in the lower intensity, they should be rating it as, a light type of workout versus the higher intensity where they're rating a little bit harder. Okay. Uh-oh. Here we go. All right, this one's on the treadmill. So on the treadmill, you may or may not notice, this is a nasal cannula, with the pillows that go in the nose. They're not really called pillows, but they look like them. It's a non-invasive ventilator with higher pressure, so you're going to probably hear it's pretty noisy. This might look like a slow run. This is not a slow run for him. This is. You guys hear the oxygen. All right, and then this is the recovery, which is a walk. You'll see checking SpO2, making sure that he's in a good range. Good recovery period. Okay. And then I did include some strength training too. We've got some chest press with dumbbells, kind of a lighter weight but faster. And this would be for like a 30-second period. And then a slower upper body exercise. Okay. Oh, just kidding. There's one more. We've got some squats holding a weight. So for some of the exercises, he is fine just using his nasal cannula. And then for some of them, he requires the non-invasive system. You could probably tell, like with the running, that was probably the highest intensity one for him. But usually with the weights, and I don't think on the bike, I'd have to go back and look, but I think the bike, he might not have needed that either. And then this is just a lower intensity leg exercise. And I know it looks slow, like it looks really easy. But I'm doing this to kind of get us away from thinking like HIIT has to look the same for everybody. Okay.
Oh, hey there. How are you?
Good. How are you?
I'm good. You actually just caught me in between sets. I've been doing some high intensity interval training.
That's great. Can you tell me a little bit about how that's benefited your workouts?
Absolutely. Well, it's been really beneficial because I spend about an hour in the morning and an hour in the evening doing my airway clearance. And then on top of working a full-time job, this approach has allowed me to fit a good workout in 20 or 30 minutes at the end of the day.
That's fantastic. I also noticed you were running on the treadmill before. Can you tell me a little bit about how you're able to do that with your lung disease?
Yeah, absolutely. Well, one of the key things is to make sure you're getting enough oxygen. So I make sure to monitor my SpO2 as I'm running. But using the high intensity interval approach, I usually do about 30 seconds of a fast run, followed by 60 or 90 seconds of a slower walk to allow myself time to recover. But this has been really great because I've been able to notice that my leg muscles actually get more fatigued before I run out of breath, which is something that I'm not used to as someone with advanced lung disease.
That's fantastic. Thank you so much for sharing. Really appreciate it.
Thanks for stopping by.
Okay, that's the end. We are going to do our Q&A now. If we have any questions on here or microphone people. Should we do microphones first?
Yeah.
Okay.
Hiya, thank you. So my question is for any or all of the speakers. I'm an adult pulmonary fellow from the UK. I think what the unique selling point of HIIT, or what makes it fun, partly or probably for me, is because it's a group activity, and people tend to get very competitive with the AMRAPs. Trying to do that in a CF center within CF patients might be limited because of the infection control measures. How would you, in your experience, navigate or even circumnavigate that if possible, and try to get buy-in from patients to do HIIT?
So I think like when I think about in like a competitive setting, I wasn't visualizing kids with CF with other kids with CF, but just with their peers that they'll be around with in general. So I haven't considered actually doing a group session with people with CF personally. What do you guys think?
Yeah, I think that, obviously depending on what you have access to from a space perspective, outdoor workouts are always a possibility, especially, with people with CF. And I think that you also hit a piece of that, of just, the sad part of this, the whole disease, right? The inability to have that camaraderie. But I do think if you do have the ability to go outdoors into a facility and the equipment and whatever you want to do, the ability to share something like that suffering of a workout, and I hate to say suffering, it sounds so terrible, but like that difficult part of a workout with someone else that you know is dealing with similar things. I mean, man, what a mental and psychological uplift for them if you can find a way to do that.
Okay. I don't know if this thing's on. I'm Heather. I'm a nurse, a CF nurse, pediatrics only, Northern California. A lot of our adolescent kids that are on Trikafta are now gaining weight, right? And they're some are athletes, some are not. We have some that are definitely not and are resorting to video games, and they're really struggling with this. And so my dietitian's here as well. And so you're talking about this would be a great thing to educate them about and to talk to them. And you guys are talking about increasing like their lung function, you know, and helping with their lungs metabolically when you're exercising for 10, 12 minutes. Are they gaining the same kind of benefits as far as caloric expenditure, and how does that benefit as well?
You have any insights, thoughts on that?
Well, I think it goes back to who you're working with, what's their level of training and stuff like that. So you're going to have to monitor it, and it has to be complementary to whatever the nutritional aspect is, right? Because the goal among many things is cardiorespiratory health, muscular strength health. How do we balance these in a sense where some are probably going to burn more, have a higher metabolic rate. Some are going to burn more calories. But at the end, try to track as much as you can and look for progressions too. There's one thing I will do when I have, athletes coming in, stuff like that. I'll use a hand grip strength, and we'll look at their hand grip strength. And if it goes down significantly, all right, we're going to pull back a little bit from kind of like a neuromuscular standpoint too. So having some type of criteria is when they come in as well to track those things as well. But I think it's hard because it all depends, right?
Yeah, I would maybe add to that. First of all, I mean, we can go all day on whether or not BMI and some of those other things are still the best, that we'll throw that over there, right? EPOC is definitely a big thing with it, but I think a big skill that we probably need to do a better job of teaching everyone with cystic fibrosis is how to monitor their intake, and I think the dietitians here would probably heavily agree with that. And then it's just that scientific method, right? We're going to do this for a period of time, monitor your intake, what happens to your body composition, your lean body mass, your body weight, what is our nutritional intake. But I mean, yeah, 12, 13, 14 minutes, you go do that for a week, 5 days a week. Tell me that energy post oxygen consumption isn't doing something for you. I mean, you can definitely get the benefits out of a 12-minute workout to help with that. Wait, what are you looking for
So
there?
we'd be okay to tell them, like, it's more our girls, our 13, 14-year-old girls, they're struggling and saying, hey, if you can put in 10 minutes and do this, you have all these benefits. So I just want to make sure we
I think you can, but I think the other thing is, the thing I would tell you is, would you rather have them doing nothing or doing 10 minutes?
Oh, 10 minutes.
So it's like,
Yeah, that's true.
I want to, quick add. Sorry, I had something to say. So, agree with all of that. It's also, and it may or may not have been clear, but faster or higher intensity like bouts actually does speed up your metabolism more than slower, longer exercising. So if you ever talk to anybody that says that they've spent, they spend an hour on the elliptical every day and they haven't lost weight, that is why. So for your patients that you're talking to, it may or may not be enough. It depends on how overweight they are, how much they need to lose, if they're, they have a higher fat mass versus muscle mass. But the quick bursts like that with raising your heart rate does actually speed up your metabolism at baseline faster than like slower, longer workouts.
Got it. Perfect.
Yeah.
Yeah, and also your metabolism stays higher longer after HIIT than it does after continuous training.
Hi, Chris Tapley. I'm from Children's Hospital in Ann Arbor, Michigan. Question for you, Chelsea. With your more advanced lung disease individuals, have you, especially the gentleman you were sharing, have they looked at CPET testing or like VO2 max testing for him to see where that's falling out? Are we seeing increases there? And obviously his exercise capacity is increasing, but are we seeing those increases that we may not catch in the FEV1?
I don't think we have VO2 testing at our hospital, unless I'm wrong. I don't think we do. Are you saying we do? Yes, we might have it at our hospital.
We don't. We have limited. So
I think that's a great idea. We haven't been regularly doing that with our patients.
yeah, I'm just curious for some of these patients that are staying stable.
Yeah.
Low, is that a way for them to track and to look at, and to also give them some encouragement for?
Yeah. So I usually I'll do submax testing. I try to do the ones that best correlate, and I know that's a topic for another day too. But like I'll typically use like a 1 minute sit to stand as like a valid submax test. I know max testing is the gold standard. We want to do that, but I would say I will typically use that at least in my wheelhouse, just to assess like their needs, oxygen needs, things like that. But I would love to do VO2 max testing, and I will find out how to do that now.
Yeah, yeah, and he maybe some of the clinical max or submax max testing, would be enough too.
Yes, but I do regular submax testing with this population.
Okay,
Yep.
great.
Thank you.
Hi, my name is Parker. I have no affiliation. I'm a community member. I just want to give a suggestion that as your patients are working out, that they should meet with a dietitian to go over their sodium intake needs, as they have different sodium needs than people without CF. And I know that there's a variety of ways they can get sodium. It doesn't have to be Gatorade. I'm sure, Coach, maybe you've seen that with your son. Creative ways to make sure the sodium needs are met. So just a quick plug there. And a question for all of you, who can do the most burpees in a minute? And if we don't know, our good friend Simon can help us find out.
My money's on Drew.
Karen Hardy, I'm at Stanford. We do, peds, all peds. We do exercise testing. So we've done that for quite a number of years, a couple of decades, of looking at our kids and trying to encourage them to get better. I'm interested in what you all do for rate of assessment of muscle mass change, or are you using bioimpedance, or what might you do regularly to track how things are going and keep encouraging your patients?
We do use a BIA machine at our clinic. Our dietitian is typically that's in her wheelhouse. So she'll see our patients, she'll do the BIA with them, get their numbers, their skeletal muscle mass, their fat mass. And then typically we will go over it with the patient. So if they have certain goals, if they're trying to increase muscle mass, we have a lot of, particularly older teenage boys, men in their early 20s, that they want to get really buff. So they love the machine. They want to look at their muscle mass. So we kind of go in together and we'll collaborate on how to help them, give them suggestions, things to do. But yes, we are lucky enough to have a BIA machine in our clinic. I don't know if you guys have that at all, Dave. No, sorry. Somebody get Dave a BIA machine.
In working with athletes, I don't recommend doing it more frequent than 4 to 6 weeks. Just because I don't know how much real change you're going to see there. And there's always limitations with any of the modalities that you go to use, unless you're doing underwater weighing or a bod pod regularly. But I think you would be, as long as you're seeing a consistent trend in one direction or the other, depending on what you're measuring, what you're looking at, that's probably the most important thing.
Do you even use something like resting heart rate change? And as they're getting better and it's coming down. Does that happen to your advanced ones?
Yeah. So they will experience typical, the same changes that we would expect with anyone who's getting in better shape. I've definitely seen that before. It's not significant, so it's usually still elevated, but I have seen better effects. And I don't know if I even touched on this before. I might have missed it, but a very elevated heart rate with advanced lung disease could also mean that they're not getting enough supplemental oxygen when exercising. So even if they're still in the suggested range, maybe they're 90%, 91%, but maybe if they went from 2 to 3 liters, their SpO2 might go to 95%, but their heart rate's lower. So those are also things to look at too, right? Like if they're very tachycardic, they might just need a little bit more supplemental oxygen. But I do use that too. That's a really good indication just with any of us, right? With better cardiovascular health, resting heart rate going down for sure.
Yeah, you might also consider a 1-minute heart rate recovery as opposed to resting might be a little bit better.
Hi, Stacy with the University of Michigan. Chris is my PT, a dietitian. I'm just curious, I haven't really heard talk amongst like PT, how you guys deal with like orthorexia right now with the advent and rising of eating disorders. Are you seeing any, like if you're athletes or anything like that, exercising too much, changing their diets too much, and kind of how do you handle that as a team?
Have you? No.
I haven't had any directly. I mean, I deal with a lot of teenagers, so I'm sure that they're there that I might just not be aware of.
Well, I think that kind of goes back to then when we're looking at body fat testing and stuff like that, of how often to test, because a lot of athletes that's turns into their goal. I want to lose a little more weight. I want my body fat to be this. And if you from the sports, if you look at the sports sector, there's not really a standard of if my body fat's 16%, I'm gonna throw 100 miles an hour. Like actually some of our harder throwers don't fall in those categories. So those things start to change when we start to be like, if we start to really emphasize, hey, if you get lower here, and then all of a sudden like, well, that's my new goal. And going back to it, like an easy thing that we use with athletes, especially when I have a lot of athletes that like to overtrain. I want to do more, is the grip strength is one of the easiest ones to do. They come in, hold the grip thing. If it's lower, we start to look maybe more mobility, maybe more breathing stuff, and then educate on that, and then just keep slowly educating with the level of trying to have their autonomy within it versus saying, no, you can't do this, but kind of keeping that rapport with them, why you're doing what you're doing, and going back to what everyone has said is what is the goal, and kind of coming back, this is why we're kind of going down a little bit. And like going back to like the sports sector of like one of the biggest way for high performers is if you talk to any of them is it's how quickly I can recover and then repeat that measure. So that's another way of how to push it is we says like, if you can recover faster and more efficiently, you're actually going to perform at a higher level, especially you have to do it over a period of time because it's not always about acceleration and stuff like that. So it's something to kind of talk about with them is from a different perspective.
All right, thank you.
We don't have any questions in the app, so if anybody did put something in the app, it might not be working. Just letting you know. Or nobody asked questions in the app.
I have a question.
Okay. Hey.
So just with like insurance limitations and visits, like because we're typically seeing these patients once a year, how often are you seeing them if our emphasis is on form and progression and monitoring?
So are you talking about like in the CF clinic, like outpatient?
Yeah, or are you recommending to go to outpatient? Are we setting them up with a supplemental kind of program or how
Got
are
it.
we going about this?
So I will start because I do see a lot of them in the clinic. I will, if this is something that they're going to like maintain on their own, things like that, I would send them somewhere else because I can't see them that often, right? And I can't do full HIIT workouts with people in the clinic. I think I probably have the same limitations that we all have with clinic time and things like that. I will at least like plant the seed, and sometimes inpatient, we will do aspects of high intensity interval training. Nothing too crazy, but at least like planting the seed of like, these are things that you can do. And then I will refer them to outpatient physical therapy. Or if they're doing pretty well and they're pretty healthy and they want to get started on their own, I'm okay with that too. But I wouldn't be able to do like constant monitoring. I'm also not giving them like heavy lifting to do either. So that might be a little bit more like in Drew's wheelhouse with higher intensity exercises, but mine are not usually as like I wouldn't feel like I would need to be with them every day.
Yeah, this is the challenge with individualizing in our current healthcare environment. For me, it's not specific in the clinic. I have the advantage of seeing CF patients in the clinic, but also when they're admitted. And when they're admitted, you've got much more time to do more education and do many bouts of HIIT for your exercise in the hospital. So that's the time when I can do more individualized care.
It's something just quickly to add to that, because I, was able to be in the clinic in private sectors. I think it's also an opportunity for us to look at the community around and reach out to trainers and stuff and try to navigate, because it's oftentimes we'll go find a trainer or find this, and it's like it just adds another barrier. So trying to reduce barriers by finding local gyms, just even to have a consultation on the phone and stuff like that to get others involved. Because going from physical therapy out to the exercise world, pick your poison. There's a lot out there, And so reducing that barrier by just trying to get others involved, even for a conversation, can be extremely helpful and insightful to build that bond.
Hi, I'm Kelly. I'm a dietitian. We don't have a physical therapist in our team. I wish we did. And a question that I field all these exercise questions, and I feel very inequipped to answer them. But I do have a question about applying HIIT. A lot of my patients will say, I only have 10 minutes, and it doesn't count if it's less than 30. So when you have a patient that says that to you, they're open to doing some type of maybe run, walk, run. And they're going to say, I can only do it 10 minutes 3 times a week. I say to them, it's better than nothing. It's still consistency, but can you give me anything else evidence-based to respond with that's compelling? Or if even less time is still compelling, anything like that?
It's probably not evidence-based, but the term all or something comes to mind. If you can't do everything you want to do, at least do something. It's going to be better than doing nothing. You'd rather get those 10 minutes because it's going to be more beneficial than the alternative of 0. Mm-hmm. That consistency is going to trump intensity all day.
Yeah, I don't have references on mine, but I know that I've seen studies that talked about dose-dependent responses. So even though maybe you haven't hit the recommendation, you're still receiving benefit up to the level that you've done. But if they've only got 10 minutes and they're interested and able to safely do high-intensity interval training or just get higher intensities within that 10 minutes, then you're getting more bang for your buck.
Thank you.
Hi there. I am sure this varies by patient and situation, but I was wondering if there are any, when you're looking at heart rate drop during the rest periods, is there a certain percentage that you're looking for deciding on your dosing of your ratios or anything that you're using in that rest period for the heart rate?
So I typically will at least make sure there's some level of recovery. So if they're just staying up high where they've been, so let's say we're exercising and their heart rate's in the 140s or 150s, and they're just not getting even below 130 or 135, that to me is not okay. They're just staying elevated. I'll use kind of exercise testing wise, there's the YMCA 3-minute step test. I know some people like it, some people don't. But that has a actual heart rate recovery list. So based on age, going down poor heart rate recovery, average, good. You can also, looking at the list, getting them even down to 50% of their heart rate max, that would be considered more in the light range. So we can go with that. I will typically also use the Borg scales or the shortness of breath scale. So if they're, I don't have them continue if they're any higher than a 2 out of 10 on the shortness of breath. So that's the dyspnea scale. That's slight.
So you're saying during the rest breaks in between the HIIT, you want them to get down to 50% or less,
50% or
2 out of 10, or 2 out of
right. So if they're still moderately short of breath during the rest break, they need a little more time. They shouldn't start again. Yeah, that's just what I use. We could debate that too, but that's just what I personally use.
Yeah, and I would add that one of the benefits of interval training is that during your rest periods, your heart rate doesn't instantly drop down. Mm-hmm. And so while you're only working hard for a short period of time, your heart rate is slowly dropping. And, in aerobic training, you want to stay 60 to 70% and keep it there for a while. You can be doing, walking, but your heart rate is still at a much higher level because it's still recovering. And so maybe an additional way, maybe not in the advanced group, is just to more think symptomatically and more time-based. Because if you let your heart rate get below that 70, 60%, then maybe you're not quite in that therapeutic range. So it'd be ideally training-wise, you'd want to get back on it before you got too low with your heart rate from an aerobic training standpoint.
Yeah, I would just say it goes back to what are you trying to accomplish?
Mm-hmm. Thank you.
Hi there. My name is Casey. I'm a dietitian from Cardinal Glennon's Children's Hospital in St. Louis, Missouri. And at our center, we do not have a physical therapist that is able to come to our clinic. So I guess my question for you all is, what advice would you give dietitians or RTs to help promote the exercise aspect? And what would you say that we could maybe fit into that clinic time to help our patients? Thank you.
There we go.
Great.
yes, a lot of clinics do not have PTs, unfortunately. There are a lot of really good resources too, just like in the CF community. I am blanking on them, and there's a big PT group here. Does anyone of the PT group want to weigh in on like community resources for people like clinics that don't have PTs? Not to put you on the spot, but I always feel bad when I'm like, oh, I don't remember. And there's a lot of people. So if you remember, come to the podium. To the microphone. However, even if you, like, if there are any screening tools, like if somebody comes in and they're, they might have advanced lung disease or they have like musculoskeletal issues, like you guys can always refer them out to physical therapy. So just because they're not in the clinic does not mean that they can't get the services. It just might be like an extra step. So even like talking about exercise, kind of finding out their goals. If one of their limitations is lung related or breathing, like pulmonary rehab is always great for that. If somebody is has injuries, or maybe they're having like balance or dizziness issues, like you can refer them to vestibular rehab. So I would say like even asking them and like having a conversation about exercising goals, limitations, like what's hard for them basically, or like what do they want to accomplish? And then even referring out for those things.
I don't have the answer to community resources, but just to piggyback on you, so refer to PT, but you can also refer to a personal trainer. Like if they're going to a gym, or if there's a local gym, like look into the resources that you have there to have them under some form of a supervised exercise plan. And some of the personal trainers do the nutrition as well, so they can help. I mean, I know you're a dietitian, so you'll be on top of that too, but then they're getting something. So I'm a PT, I will stand up for my profession, but you can also do this through personal trainers and get somebody else that can, help with the exercise. And some of the hospitals that are connected with these clinics also have exercise physiologists, another great resource if you have that in your facility and you can't get them to PT, but I don't have the community resources though.
Breathe Strong. That's what I forgot.
What is it called? Breathe Strong?
Should I be, we could promote that for the grants, the exercise grants.
Oh, yeah. And yes.
That's what I was
Go
thinking.
ahead.
No, go ahead. Sorry. We figured it out. It was the tip of my tongue. There is a exercise grant through Breathe Strong. They usually open it up every 3 months. I think it's quarterly. But they provide resources for people with CF that want to exercise that don't have the funds. It could either be like for a gym membership or home equipment. So you can encourage your patients to go online and apply for that. They just have to send in an application, why they want to exercise, what they need. And we've had quite a few people get those resources like gym memberships, personal trainers, home equipment that could help with some of those barriers. Because a lot of our patients, while we might recommend those things, they can't afford them.
I just want to quick add to that with the Breathe Strong Plus. It's not just exercise grants. It's an app that can help to keep them motivated as well, that workouts are offered, wellness, nutrition, all kinds of stuff. So it's a lot more beyond just the grants. So definitely a good resource for people.
Thank you, Karen.
Awesome talk. Chelsea, I got to give you props. When your patient was doing his low impact resistance, his posture was amazing. That's what I saw. And I was like, man, you have to be so proud of yourself because he looked great up there.
I will let him know.
Yes. But one of the things I wanted to say, since Chelsea, you talked about time, and I learned this at NACFC a few years ago, and I try to promote it with my kids, is while they're on the vest, since that's what we use a lot here in the U.S., is getting them to be active while they're on the vest, doing some squats, doing some marches, doing some modified jumping jacks, so punches. There's lots of ways that they can be active to get that exercise that we're recommending while they're stuck to the vest. So I just wanted to say that, since time is such an issue, it's something that I was taught a few years ago at NACFC. So thank you all, though. This has been such a great talk.
I love that. Thank you. We are out of time. In fact, I think we're 5 minutes over. Sorry. Thank you, everyone, for coming and for spending your last day at the conference with us. Sorry.
Oh, no, you're fine. Well done.